Hi, my name is Eric Curtis, and I will be performing part 3 of my head-to-toe assessment for Nursing 383. I'll begin where I left off from part 2 and start with the abdominal assessment. Typically, we would have the patient's abdomen exposed for direct visualization of the skin, taking note to any variations in skin color, presence of any lesions, any scars, taking note to the symmetry side to side, contour of the abdomen, and then observing for any peristalsis or pulsations that may be present. Moving forward, we'll then have the patient place her chin on her chest and inhale deeply and exhale. And at that time, we can again visualize with that position change any muscle separation or the presence of any hernias that may appear. So then we will then auscultate the abdomen for normal bowel sounds using the diaphragm and the stethoscope. Starting in the right lower quadrant, listening for tinkling or gurgling sounds that are indicative of normal bowel function. Just go in a clockwise fashion, listening to all 4 quadrants. Typically, normal bowel activity, you can hear sounds every 5 to 15 seconds. And important to note that upon little activity, it's important to listen to each quadrant for a minimum of 5 minutes before declaring absent bowel sounds. With this time we can then auscultate the aorta, superior to the umbilicus, and we use the bell of the stethoscope for that, listening for the presence of any bruits that may indicate a blockage or stricture or the possibility of an abdominal aneurysm. And then superior and to the left of the umbilicus, we can listen to the left renal artery, and oppositely the right renal artery. And then inferior and to the right of the umbilicus, we can listen to the right iliac artery, and again oppositely the left iliac artery. And again, we're taking note to the presence of any bruits that may indicate a blockage or aneurysm within that vessel. Moving forward, we'll then perform percussion on the abdomen. Again, starting in the right lower quadrant, we will just percuss up around clockwise in a systematic fashion. And typically over air-filled spaces or hollow organs, you would hear a tympanic sound. Whereas up in the area of the liver and the spleen, you would hear typically a more dull sound with those solid organs. In the instance of a colon that is fairly full of stool, there's a possibility that you may elicit a more dull sound as well. And then also as we palpate, we watch the patient for any nonverbal signs of tenderness that may be elicited as we're percussing along the abdomen. Following percussion, we then do light palpation. And again, starting in the right lower quadrant, we'll just palpate lightly with one hand, noting any superficial masses that may be apparent, watching the patient for any signs of pain or tenderness as we move along. And then we can follow up with deep palpation, and here we can detect any deeper masses that may be present, and again watching the patient for any signs of pain. In deep palpation, we can also estimate and palpate the liver and the spleen. So we'll take a hand on the posterior costal margin, apply pressure upwards to bring that liver more interior, and then as we palpate, we'll have the patient take a deep breath in and exhale. And the liver can be palpated, the margins of it, of the liver, and size can be estimated. Oppositely, we can do the same with the spleen, upward pressure on the posterior costal margin, deep palpation, have the patient take a deep breath in and out. And we can determine any splenomegaly that may be present upon palpation. So moving forward with the palpation of the abdomen, we would palpate the aorta and midclavicular line on either side. We just palpate and we're feeling for any pulsations that may be present on either side. And then also determining an estimate of the aorta, which typically is less than 2 centimeters. Anything greater than that may be indicative of an aneurysm. To follow up or finish up the abdominal assessment, we would then palpate femoral pulses on either side, taking note of rate, rhythm, and quality. And normal finding would be +2 on the femoral pulses. And we would also palpate inguinal lymph nodes on either side, taking note of any swelling, tenderness, or warmth that may be present. So that concludes the abdomen assessment. While I have her supine, I will do her hip assessment as part of the lower musculoskeletal exam. So to begin, I will take and apply light pressure inward on both sides of the hips. And I will be feeling for any clicks or crepitus that may be present. I'll be watching the patient for any grimacing or guarding to indicate any pain. I'll then do some range of motion, and we will start with some adduction and abduction. And then we'll flex the knee and hip, and we begin adduct and abduct. And then we will do the same on the opposite side. Adduction, abduction, and we will flex, adduction, and abduction. And again, we'll take note to the ease of motion. With our hand on her hip, we can determine any clicks or crepitus that may be present through that range of motion in that joint. And we'll again, of course, be watching the patient for any indicators of pain. So at this time, I think I'll have her hop up onto the stool here, and we'll move forward with our exam. Moving into the lower extremity assessment, we would typically have the legs, both legs exposed to visualize the skin. Again, taking note of any color variations, specifically in the lower legs, as venous and arterial deficiencies reveal vast color differentiations in the lower legs. We will note any hair distribution patterns, particularly within males, from top to bottom. We will palpate the skin for any temperature, any tenderness. We'll palpate the joint, lateral and medial, portions of the knee and the kneecap, the popliteal. Palpate down the lower leg, and the lateral and medial malleolus, and the calcaneus, the top, bottom of the foot, and the toes. And we will, of course, do this on both sides to detect any changes in symmetry. Lateral medial malleolus, calcaneus, top and bottom of the foot. Again, we're taking note for normal muscle mass, any signs of any atrophy that may be present, or hypertrophy, particularly in the calves. As we palpate, we will watch for tenderness behind the knee, any excess warmth in the calf, indicating possible DVT. So at this point, we will do some range of motion with the lower extremities. So we'll just do passive extension with her leg, and again, feeling for any crepitus or clicking in that knee joint. We'll do this passively, and then we would have her do it actively on both sides. Okay, good. And then we will test a little strength, so I'll have you resist my pushing forward. Don't let me pull. Don't let me push in on your knees. Don't let me push out. Okay, good. At this time, we can check range of motion of her ankles. So I'll have her extend her feet downwards, and we'll flex up. Okay, good. And then we can rotate. Good. And then don't let me pull up on your feet. Good. Don't let me push down. Good. Okay. So range of motion in the lower legs is within defined limits. Typically, would be rated at a 5 out of 5. At At this time we will check her pulses in the lower extremities, starting with the popliteal pulse. On both sides, again checking rate, rhythm, and quality, and noting any deviations in symmetry from side to side. We have the posterior tibial pulse between the medial malleolus and the calcaneus. And again, we'll check on both sides. And that typical finding on a normal pulse would be +2 again. And then the dorsalis pedis pulses on the top of the foot. And again, checking side to side for symmetry of those pulses. So that concludes that portion of the lower extremity exam. It's important to know that as you're doing a musculoskeletal exam, you're observing the patient for proper gait, proper balance, any muscle atrophy that may be present, ease of coordination, ease of movement, and any signs of guarding due to tenderness that may be present. So at this time moving forward, we will move on with testing a little fine motor skills and coordination, and I'll just have her do some finger to thumb movements. Okay, good. And then I'll have her take her index finger, touch her nose, and then to my index finger, and then your other hand, and again. Okay, good. And then I will have her, as she sits there, take her heel of one foot and run down her shin, and then on your other leg. Okay, good. So at this time I'll have her stand, and I'll have her bend over, touch her toes, and hold. Okay, good. So at this time I can inspect her spine for proper curvature, any abnormalities, take note of the spinal processes, any deviations in those, and then you can palpate up the spine and notice any tenderness that may be elicited at that time. So we also testing flexion of the hips with that test. So that this time we can have her extend backwards with her at the waist. Okay, good. Then laterally both directions. And then rotate. Okay, good. And again, range of motion is a 5 out of 5 on that exam. So we'll finish up by having her walk towards the camera in a normal gait. Okay, turn around and then walk back heel to toe. Okay, good. So as we're doing that, we're watching her coordination and her balance, if she sways side to side, and all that was appropriate. So the last test we'll do is the Romberg test, and so I'll have her put her feet together, hands at your side, and for 20 seconds with her eyes open, we'll have her stand in this position, standing close to the patient, guarding her in the event that she were to lean one way or the other. So after 20 seconds, she is steady. We'll have her do that again with her eyes closed for 20 seconds. Again, standing close for safety. Okay, good. And testing balance and coordination through the Romberg test. That concludes part 3 and my head-to-toe assessment for Nursing 383. I'll finish up by washing my hands, thanking my wife for being my patient, and thank you.